we are. Please take your seats. Gentlemen and ladies, ladies and gentlemen, take your seats. This is the court of law and no bias for any gentleman or any lady. Everyone is a surgeon, and that also transcends to any hanging that can take place. Even the smartest of young men or the most beautiful of all ladies can be hanged. So be prepared. Lahane sir ko. So we start off with court martial, and let me tell you, this is a very, very big moment for all of us. And we started all the way back in 2010. 14 years ago, we started court martial, and this was a view of the court martial that we had. And can you see Professor Lahane giving his verdict even then? He is still here now, and I'm sure he's going to hang every one of these glamorous surgeons who have done wrong. So here we are, and this is the 125th session of court martial in ophthalmology. A big rousing applause to everyone who has participated in court martial. We have been in India, every state of India, every nook and corner. We have gone abroad to APAO, we have gone to SNEC, we have gone to Bali, we have gone to Kuala Lumpur, and in the international scenario, court martial has been acclaimed. Now it's my proud privilege to call upon our supreme judges, Professor T.P. Lahane and Dr. D. Ramamurthy. And as is the protocol, everyone has to rise on their feet. The court shall rise and welcome with a rousing applause our two judges, You may now take your seats. And it is again my pleasant duty to introduce to you someone who says, I'll be there for you. Dr. Chitra Ramamurthy, the bestest defense counsel. She will defend any crook, anyone who has done a slaughter, a murder, but she will defend passionately. So a big hand for Dr. Chitra Ramamurthy. But I'll also be there for you. And I'm a very, very sweet person, very nice, very good everywhere to everyone. But today, this is the court of law, and in the court of law, it's justice that prevails. If someone has done wrong, we have to have that verdict that you have done wrong, and you have to bear the brunt of the penalty of anything that has been done wrong. And now we welcome our honorable jury members. Mere aankh pe aankh mila ke dekhte raho. So our jury members are Dr. Mahipal Sachdev, Dr. J.S. Tatyal, Dr. Lalit Verma, Dr. J.S. Bhalla, Dr. Amit Porwal, Dr. Somshila Murthy. Dr. Somshila, have you had your cup of tea? You can join on the stage. Dr. Amit Porwal, Dr. Bhalla, Dr. Mohan Rajan. In the format of court martial in ophthalmology, the presenter presents. I, as the rude public prosecutor, will prosecute. She, as the defense counsel, is going to try and save every murder, every butcher. But the jury is most important because they will give the actual take-home pearls, the good wisdom that you have to go back with and set it up in your day-to-day practices. So, with your permission, shall we start the proceedings, sir? So, shall I call upon one of our fantastic heroes of cataract surgery? He has a true lineage of doing a cataract surgery over generations. So, a very, very young and a dynamic surgeon, Dr. Shail Vasavada. He is also responsible for maintaining that dignity of his family lineage. You know what I mean? Yes or no? The family lineage of the Vasavada family. So, Shail, with hand on your heart, take an oath in Gujarati.
હું જે પણ કરું છું હંમેશા પેશન્ટના હિતમાં અને સારું જ કરું છું. So whatever I do, I always do in the best
You don't
interest
have to
of the
translate.
patient.
There are people who know Gujarati, and that's fine. So, can you put? So, Dr. Shail, shall we play your video?
Yes, sir. Yes. So this was a 42-year-old male planned for his second eye posterior polar cataract, and we prefer to do flax. This was his second eye plan.
Dr. Shail, I have made a big grave mistake. Invite to our Bangladeshi jury, Dr. Ziaul Hassan. Please give him a big round of applause. Dr. Zia, do we have a chair there, sir? Dr. Zia, please come.
Start all over again.
Yes,
You need one more jury chair.
we will have, we will have.
I think two more. Dr. Ditya's also.
Ready?
Yes. So it was a 42-year-old male planned for his second eye posterior polar cataract. First eye went off very nicely 1 month ago, and we prefer to do the flax. And having followed all the principles of closed chamber technique, we were able to avoid a posterior capsule rupture. But while injecting the IOL got a little stuck in the incision. But because I'm injecting under cohesive viscoelastic and this IOL unfolds very slowly, I'm not very worried. And I have nicely manipulated now the IOL right in the center of the bag. Now this is one area of blob that you see in the center which went unnoticed at that time. And as always, I go behind the IOL to make sure that all the viscoelastic is removed from inside the capsular bag. But while removing the viscoelastic, what I noticed was a large posterior, and my hands are actually trembling. This is not a video error. So now I have a single piece multifocal IOL in the bag, second eye. The ideal teaching is explant this IOL, never place an IOL in the bag if there is an irregular PCR. But this is a very tricky situation. So I thought this is the best way. The surgery is almost over. Let me just leave it as it is. Let me just center the IOL, hydrate the wounds. But as luck would have it, it did not center, and therefore we have to make sure whether any vitreous has come out while doing the irrigation aspiration through that open posterior capsular tear. And sure enough, there was vitreous present, as you can see stained here. So our approach for doing vitrectomy is to do the pars plana approach. So the irrigation is through the side port, and you'll notice how beautifully this stained vitreous gets dragged in or gets sucked in through that pre-existing posterior capsule rupture or the rupture that I created while injecting the IOL. And you'll notice that there's hardly any turbulence that is occurring around the posterior capsular tear margin. And all of that vitreous has now drained through that, and now we have removed the connection between the posterior compartment and the anterior compartment of the vitreous, which means now the traction is not likely to be there. So this free vitreous which is now stuck at the incision, you can go ahead and remove through the limbal route. Therefore you have done an adequate vitrectomy not only behind the capsular tear but also in front. And this is the advantage of pars plana, the ergonomics, which means you do a vitrectomy even around the posterior capsular tear so that you remove symmetrical vitreous from all around the posterior capsular tear so that there are no unequal pockets of vitreous being left behind, which will make sure that the tilt of the IOL is not there. So I'm still keeping the irrigation on and making sure that the wounds are hydrated well before I remove the irrigation or let the chamber collapse. I'm constantly praying not only that this IOL remains stable right now, but the real test will be tomorrow when I see this patient post-operatively, because there's an irregular tear which is extending up to the equator, not a posterior capsule or axis, which I would be very confident about. So this is the patient at day 7, very stable, very nicely centered IOL. This is at 6 months. Very stable, well-centered IOL, and this is at 3 years, hardly any PCO with the rest of this square edge, making sure that the PCO doesn't come up. It's always very important that any eye with an event get a peripheral macular evaluation, peripheral evaluation done, and this is the IOL, very stable, no tilt of the IOL, no internal aberrations, very centered and stable. So I think in a posterior polar complication can occur at any time, even when you think this case is over, but do not panic. Follow all the steps that you have learned in a normal complication. It will work irrespective of the stage of the complication when it occurs. Triamcinolone and pars plana can come to your rescue even after the IOL is inside the bag and you have a PCR. And any difficult situation can be salvaged if we follow all the principles that we have learned from all our teachers, including the public prosecutor. Thank you so much.
Thank you, Dr.
A point to
Shell.
note, the case is closed.
Is it? On what grounds? Please maintain the decorum. After the presenter has presented, it is the prerogative of the public prosecutor to prosecute him, and let this slide be. So on this slide, we have a very important submission. Complication in a posterior polar cataract can occur at any time. Agree or disagree? Agree. Agree, Shell?
Yes, absolutely.
Yes. Do not panic. Agree. Agree?
Agree.
Wow.
He's just trying to
Situation
terrorize
can
you.
be salvaged. Agree. I too agree. Now, Dr. Shell, I begin my trial. So, first I tell you, do you plead guilty of placing and having in your whole protocol the possibility of placing a multifocal IOL or a trifocal IOL, which you have counseled the patient with a posterior polar cataract? A posterior polar cataract, and you have said to the patient that this is the best lens for you. There could be a PC rupture, yet this would be the best lens for you, dear sir. And the patient agreed to your sweetness, the trust that the patient had. Were you correct in counseling a patient of posterior polar cataract with a trifocal? And that's what the courtroom is going to answer today. So, you plan a flax with a multifocal. This is absolutely bad planning, and it exudes overconfidence. Why did you tilt that IOL with, you know that that capsule has a possibility of a rupture going at any time? And I would suggest that you created that PCR. And it was absolutely unnecessary to go under the IOL and irrigate, and a fragile
Objection, Your
PC
Honor.
could have been
I
done.
waited long enough.
No, you have not. You will wait longer. The next steps were appropriate, Dr. Shell. You created the whole gamut, but the next steps were absolutely fine. But this eye, this situation could be salvaged, which does not mean that you give a take-home message to every one of us that you go ahead counseling your
Objection,
patient with a
objection.
PPC, with a trifocal, I find you guilty.
Objection, Your Honor.
Okay, go ahead.
See, it is absolutely meaningless. He could have picked up some very valid point there, which he has not. I will teach him that later. Now, why can't you put a multifocal IOL in the patient? You could tell the patient there may be a PCR, and this PCR did not occur because of that PPC cataract. It was an inadvertent small error which happened.
Error.
That is, in that,
Is that guilty or not?
no, it is not guilty.
Yes, an
The
error
PP
happens and he is
No,
not
I am
guilty.
answering for the flags with multifocal. Why should the audience think that you don't put multifocal IOL in a PPC? You counsel the patient, and if the patient still wants, you can go ahead and do it. And invariably, with flags, PPC, you don't have problems. Finish. The second one is, why do you tilt the IOL? He didn't exactly tilt it. He removed viscoelastic from behind the IOL instead of leaving a blob of viscoelastic behind the IOL. That is
And
all. That
ruptured
is
the
all.
PC.
There was no butchering of the PC. There was everything was done so well. All of us should be told it's a wonderful presentation. All of you learn how to do a pars plana vitrectomy and deal with it so that the size of the PCR doesn't increase and the IOL stays stable. That should have been an actual teacher teaching. So sorry.
The court proceedings, can we have the jury commenting?
Dr.
Somshila,
Somshila, pay attention and please
don't
tell a
dictate to the
scientific-
jury.
Yes.
Science, please.
She was looking at,
Google.
Looking at literature. No, I think that in this, I think what is on trial here is that whether the patient was counseled appropriately, knowing fully well that there's a PPC, is it appropriate to counsel the patient for MFIOL or trifocal, whichever technique. So the defendant has mentioned that the counseling was appropriate, and as long as the surgical skill is very high, I do not find the defendant guilty if the counseling was that you could have a problem, and in which case we won't put this lens.
yes, Dr. Bala?
Can we just answer for science sake?
No, we'll
Two or
take
three
it
questions.
up, we'll
Let
take
us
it up in the
finish.
end.
We will
We'll summarize in the end.
I think we can divide it into various subheadings. The first part was the counseling. I think adequate counseling was done, and the patient was told also that we'll try to put multifocal IOL in posterior polar in case there is no complication, and in case of any inadvertent PCR, things would have been differently managed. And second part was the tilting the IOL. I don't think it was a tilt. He was just trying to remove the viscoelastic blob, but it could have been, instead of particularly for me, instead of in a posterior polar cataract going behind the IOL, I would have just rotated the IOL and tried to take out,
Is he
leaving behind
guilty
a
of
little bit
that?
of viscoelastic. And
Dr.
third
Bhalla.
part was the PCR management. I think it was very nicely managed, and the end result was what shows that it was situation which happened inadvertently was salvaged very nicely, and the end result which he showed was adequately well-centered IOL and with good vision to the patient.
Yeah, Shell very nicely managed. For anybody, I think, who's handling a PPC cataract, multifocal IOLs can be counseled, provided you tell the adverse effects also. I mean, tell that the complication can occur. You should have a backup of a 3-piece multifocal IOL in hand, and you should tell the patient that if you're not able to put the multifocal, you'll go for a single, a monofocal lens. Second thing, the visco wash behind the IOL. See, I also do the same procedure for every case, but for PPC, you have to alter your technique a bit. I wouldn't recommend anybody to go with the irrigation port behind the IOL. Irrigation port behind the IOL, because the jet of the irrigating fluid, if that hits the thinned PC area, you will get a PCR. So that particular step should have been avoided, but you have managed it very nicely, so I don't say you are guilty.
Full compliments to Shail for a wonderful, I think, demonstration. You should all give him a big round of applause. The only thing I would differ is, I think it was a wound-assisted IOL implantation. That is what you should not do in a PPC. Please understand that small amount of jerk, that small amount of force, it's not because of your going underneath. It has occurred during your IOL implantation. If you notice that video very carefully, there was a small PCR at the time of implantation. Because of the sudden jerk, because of wound assisted. In a PPC, what you do is, go inside and make sure that you gently put the lens in the bag. Okay, you can't remove the viscoelastic, that's all fine, all other things are fantastic. Otherwise, got an uneventful multifocal lens, you managed it very well, great to you. But this is the only point I want to tell everybody, take home message, don't do wound assisted. Any sort of force can open up the PC. Again, when you come out, inject viscoelastic through the side port because you don't want the PC to come forward. When you come forward, the AC shallows, the PC will open up in PPC. Thank you.
I think like the jury nicely summarized, it was a
Dr. Lalit,
difficult.
No, despite managing very well, but I still feel.
No, jury.
Let me finish defense counsel. You see, 2 wrongs and 1 good. 1 good was you did a pass vitrectomy, which was very good, and you managed it very, very well. But two wrongs were there. One is that in a PPC, it's very good to go behind the IOL and wash, but in a PPC you have to be ultra careful. And secondly, despite having a big PCR, putting a multifocal in a big PCR, you can go ahead and do whatever you want.
The IOL is already inside the bag.
Defense counsel.
Let it be. You see, can put multifocal in PPC, but not in the presence of large PCR. That's what my 2 points are. Therefore,
I think.
Therefore, this is the last.
I think the jury has given nice comments on a very difficult case. I feel looking at these points alone, just summarizing what the others said, there's absolutely nothing wrong in counseling if the patient wants a multifocal lens or a trifocal for a patient with a PPC, because the incidence of PCR is just about 3 to 5%. Did you do an ASOCT in this case? Before this
No,
surgery?
so sir, actually the posterior capsule was very much intact before the IOL was implanted. What I feel what happened was, like Dr. Mohan Rajan sir correctly mentioned, the injection was not very smooth. And probably while injecting, the IOL margin brushed the posterior capsule, which was not noticed before I
No,
went
I would
behind
still
the
say
eye.
that, I think especially in a place like yours,
Yes,
an ASOCT is a de jure because if in case you find that there is a defect, you are going to counsel the patient.
Flax OCT.
And
will give that.
secondly, you said you use cohesive viscoelastic.
Yeah.
And in that case, there was really no need to go behind at all. Just hydrating the wound itself, sometimes the entire bolus just comes out.
Okay.
And just a last question, in case it was instead of a trifocal, it was a toric and troch lens, what would I have done?
Sir, I would have, with this situation with the IOL inside the bag, there were only 2 options which I could have thought of. One was doing this, and if the IOL remains stable, I would leave it like that even with putting it in the toric axis. Or the second, which could have been in this case, because of the flax, I had done a very small rexis. I could have thought of reverse capturing the
Reverse
optic,
capture.
that is the optic above the anterior capsule.
Yeah.
Good. I think.
Is the discussion
yeah,
over?
Can we? Yeah, it's over. Judgment? Somashila?
Yeah.
So I think it's. I think it's 1 against 4. So.
Since the whole thing is done, just one note for the audience, that haptic was actually lying in the area of the rent. So when you had done a good vitrectomy and there's no vitreous and eye is stable, you could have just dialed the haptic away from the area of PCR. This was not a toric.
Yes.
You could have dialed away at the PCR, and if at all, the only other thing was reverse optic capture if it was a toric eye.
Fees was very, the fees amount was very high for you, I think. You defended him very nicely.
So, Garland, Shell. Welcome, Dr. Anaga Harur. Rohit. hand on your heart, Dr. Anaga,
Yes, sir.
and in chaste Marathi, your
Yes, sir. Whatever, मी जे काही करीन पेशंटच्या हितासाठी करीन.
was that fine?
ठीक है.
No, but based in Maharashtra. So shall we start?
Yes, sir.
Are you all ready, Dr. Anaga?
Yes, sir.
I have one disclaimer. The court of law will not be mesmerized by beauties on the stage.
So I'm presenting some cases of toric IOL. So this was a 67-year-old female where we had planned a right eye cataract with toric IOL. As you can see, the K1, K2, it was against the rule astigmatism with a cylinder of 4.25. And this was the toric calculation. Actually, this is a 10-year-old case. And we were using the ZCT 525 model with the IOL orientation at 13 degrees with a residual refraction of 0.02 at 103. But on the 8-day post-op, we found that this was the AR, plus 3.5, minus 7.25. So the spherical equivalent was almost 0. And the IOL axis was at 103 instead of 13. So then we had to fix it. So we went on to www.astigmatismfix.com, where you need to put in the refraction, the present IOL orientation, and the cylinder of the IOL. And it gives you how much you need to rotate and whether rotating will help to reduce the astigmatism. So obviously we had to actually put it at 10 degrees or 13 degrees, which was the prior calculation also. So we went in again and opened up the side ports. As you can see, the capsular axis was nicely covering, the anterior capsule was nicely covering at 360 degrees. We went in, put in a little viscoelastic and opened up the anterior capsule. We had marked the 0-180 as well as the IOL axis. And now all we had to do was to go in and rotate it to the desired IOL axis now. Once that was done, we now removing the viscoelastic. So one of the most important things here is that we need to rotate it very, very gently. And since this was around 8 days post-op, it's quite easy to rotate the IOL. What is important is we need to diagnose this early so that we don't wait till 3 to 4 weeks when probably it will start fibrosing. So this was done at around 8. Usually they say IOL rotation you can do around 8 days to around 15 days post-op, and this was the same patient 4 hours post-op where the IOL was still at 10 degrees axis and it remained like this. So this was 5th day post-op and the patient did well. So basically early diagnosis will help to pick it up early and then you can manage the case well. So this was another patient where the surgery was started. This you can see the perfect capsular axis, a very good hydrodissection, hydrodelineation, phacoemulsification, and a very meticulous surgery, irrigation and aspiration. So till now there is absolutely nothing. We are now putting in the IOL. This was the toric IOL. So now when we are putting it into the bag, still there is nothing. And now please watch. Now I had to rotate the IOL and I was trying to remove the visco just like in the first case from behind the IOL, and you can see that at this point of time the patient moved and there was a PCR. Unfortunately the PCR was in the same axis as where the haptics would have been. So now the dilemma here was whether to rotate the IOL or not. Now at this point of time the PCR was only in the periphery, so I first put in diluted tricot to check whether there was any vitreous and did a thorough anterior vitrectomy also. And I was in two minds whether to rotate the IOL, but by rotating the IOL there was a chance that probably the PCR would increase. And this patient had just a 0.75 astigmatism, and the other eye the patient was already using a 1.5 diopter cylinder operated elsewhere a few years ago. So I decided to leave the IOL like that. The patient had a very good vision post-op of 6x6 with just a 1.25 cylinder, and the patient was counseled about it. Patient was happy and the vision was good. Patient was happy with the vision and both eyes the patient was using glasses. So this was what at that point of time I thought was best in the interest of the patient. Thank you.
Thank you. Shall I begin my
I
trial?
hope you stay benign till the end.
Shall I begin my trial, sir? I shall. Okay. So, Dr. Anaga, this is a very, very nice way of demonstrating what you have done. But there is a story behind this. Do you agree or do you not agree?
No story.
I'm going to tell you the story.
No,
I'm going to tell you the
But
story.
you can't create stories when none exist.
I am going to tell you the story, and it is a personal communication from Dr. Anaga to me, which I need to tell and apprise the courtroom. The story is, in the first case, Dr. Anaga leaves all her calculations to her OT assistants and her optometrists, which most of us do, but she does not cross-check on what they are giving, which lens they are giving, which axis.
Objection, Your Honor.
No, you have
Now
to
this
let
is all
me-
fabrication.
No, it is not. It is not.
It is fabrication.
And the OT assistant told her, Madam, it is at 10 degrees, where it was at 110 degrees.
No, no, sir.
Yes or
Fabrication.
no?
So 1 minute, sir. The communication was that I had confirmed it with the staff and the IOL had rotated. It was at 100 degrees was the residual astigmatism. But the IOL axis was at 10 degrees.
Yes. So IOL axis was at 10 degrees. The staff said the IOL axis is at 110 degrees.
So the
And that's
IOL
how-
rotated, sir.
IOL rotated.
Okay, that
You
is
have
an-
to be,
That is
understand,
an
don't be gullible.
afterthought in this
No.
court of law.
No, no afterthought.
So we have the
Dr. Anaga?
entire calculation
Sir.
pasted on the
Dr.
OT.
Anaga, can you be
I think,
truthful?
please proceed, just,
Okay.
we have 3 more.
So this is the story, and 110 to 10 degrees is what the culprit is or the guilty is. It's not Dr. Anaga, definitely not. So let's go ahead. So this glamorous surgeon, and it's actually a take for every one of us. We do rely on our optometrists, our OT technicians, who are brilliant, but they can make mistakes, they can flaw. So believe all, but trust none. So this was a case in which you had to subject this patient to a second surgery, and it was unnecessary. The second case, again, was a repetition of our previous case, Dr. Shell Vasavada's case. Again, Dr. Anaga carelessly ruptured that PC. And for that, we find you guilty.
Objection, Your Honor. So we won't go into building stories in a particular case. So yes, I mean, his message was relevant to this case. But any of us, there could be transcription errors, and these we all know that could be part of it. Besides the plausibility of rotation in a very small percentage of cases, which is why rotation should be done by 2 weeks latest. So I think we put that aside. The second case, she has done very well. Yes, there was a PCR, but what she has taught us is you have to have the courage to have told the patient there may be residual error, and at that time, rotating the lens could have been hazardous, and she has looked it up that it was a small residual against a risk of PCR enlarging. Of course, the axis was round, and as in the previous case, in this particular case, you could do a reverse optic capture, but then again, the axis would have been an issue. She couldn't have placed a haptic there. So I think leaving it aside was the best option, and one can't be pronounced guilty for telling certain learning tips to our people and how beautifully it was managed.
Your Honor,
Can we
I
have
have
the
just one
jury?
small question, Your Honor.
Can I
One
make a
just small
comment?
last question.
Can I make a
Dr.
comment on
Anaga,
this?
1 minute, sir. Dr. Anaga, hand on your heart.
Which heart?
Did
She has
you,
no heart.
did you refund the amount of a toric IOL surgical fee to the patient?
Why should
So in the second case,
First case.
so
No,
we
first
gave
case
the
she
patient
rotated
6 by
and
6
all right.
vision, sir.
So what was the charge for the next OT?
we don't
The
charge
zero
for
charge.
toric IOL rotation.
Nobody
did it?
charges.
Three
Did you
netralia
do?
has grown to
Let
that
her
level because
answer.
we
Oh,
do
please
rotation
stop this,
charge.
please stop this.
Okay,
Yes,
now
Doctor.
No
we will
charge.
ask one by one.
Yeah,
TTL,
just-
sir.
Let me comment on the second case first. Because other eye already had 1.75 SIL, and this eye only had less than 0.75 SIL and monofocal IOL. So normally people don't go for toric in such a situation, unless it is a trifocal or multifocal lenses. So that is one area to think about. Why unnecessarily put patient for a toric lens which has a slightly higher cost than the normal monofocal lens. Second, if you see your haptic orientation when you inject the lens, sometimes the haptic, these are little rigid lenses, the lens you are implanting, and when you go inside with the sudden opening of a capsule or bag, the haptic can touch the posterior capsule in a different manner. So this is one careful observation we have to do it. First case, yes, it was very surprising if what Partha is depicting is correct. Like you wanted to place lens in 110, it was found to be 10 degrees, which is such a large rotation is not possible in a routine cases. Either it is a lens patient with a myopia, big bag, otherwise it doesn't happen. So this is it would be a definite mistake in the orientation of your lens, as you were trying to tell. Maybe somebody told you a wrong axis to be implanted.
I just want a clarification. Did you use the Varion overlay for the first case?
So this was a 10-year-old, at that time I
No,
didn't have the
because,
Varion.
sometimes with Varion overlay, what happens is, because you say exactly by
Yes,
90
exactly.
degrees.
There are those
instead of,
marks even at 90
orienting
degrees,
on
I
the flat
agree.
axis, you orient it on the
Yeah, so
steep axis.
no, I was not using it that time.
So, Mushila,
Sure, sure.
in brief, huh? In brief.
In brief, I don't have any additional points except that depending on the lens company, some of them have very stable lenses and some lenses are more liable for rotation in the bag, and some of the factors are rubbing the eye and so on. I don't know if that really is a cause. Otherwise, the high myopes, as Professor Dityan mentioned. I think the first case was very well managed. In the case of the second case, also I think that it's the surgeon's conundrum what to do in such a situation, which was honestly presented. I don't think the intent was to do harm.
Acha, Balla sir.
But harm was done.
So in the first case, I tend to agree with Dr. Tityal that the toric lens was set at almost with the rule astigmatism, but then it was almost horizontally. So I think in routine case, except in large myopic eyes with extreme axial length, this normally is not possible. And but in the second case, I think I would have done the same thing, because once they trying to rotate the haptics in that direction would have been hazardous. I would have settled with little bit of astigmatism, because that was the best solution in rent in the axis of placing toric IOLs.
Amit.
Because the same thing what Dr. Tityal sir had mentioned, except for the second case, I think pre-operatively it looked like a PPC cataract.
No.
Okay.
It
And
wasn't.
what could be the reason for such a high rotation? I mean, I think it is a human error. If it is a rotation cause, did you analyze why the IOL got rotated so much? Because we don't have so much of rotation seen.
Yes.
So did you analyze that?
Yeah, of course.
What was the reason for this rotation?
Might
So
have
that
been
is
some
what
little
there are
visco
some
left
cases,
behind or
yeah.
something.
Maybe.
It has happened
She
now.
left the visco again.
We don't have
No,
90
no,
degrees.
it can happen. It's not impossible for rotation.
yeah.
It has rotated.
Okay, sir.
Come, sir.
No,
Judy.
want me to say?
Yes.
No, the first thing is all toric IOL patients, I ask them to lie flat. I keep them for 1 to 2 hours, check the IOL axis on the slit lamp, and then only send it. Because the maximum rotation occurs within the 1 or 2 hours. So this rotation from 10 degree to 110 degree is something which is very abnormal. Second thing is, again, same mistake what Shale did, the jerk with which the lens came, second case. Jerk in which the lens came, the toric lens, that actually ruptured the PC for you.
No, sir.
Yeah,
if
because
you see the
if you-
video,
if you
I've
notice
seen it
that-
100 times, sir.
Huh?
So actually, when the lens was put in the bag, there was no PCR. But when I went in
But when you see
behind
the video,
lens,
when you see the video, it comes with a jerk.
no, sir. I mean,
Yeah.
with due
No
respect, when I've analyzed it, I mean, at least 100 times,
Rohit?
it is when I
I
went
think,
behind and the patient moved a bit.
Yes.
I think she was fully justified in everything, but I would like to stress one thing, that post-operatively we should always check the visual acuity maybe 1 day after surgery. And we can come to know, as soon as possible. But what she did was perfectly fine. There's nothing, because this is all documented that at times we have to rotate, so there's nothing wrong with it. And in the second case, you know, you can opt for, the patient might have got surgery initially in the other eye. She might have thought of going in for bioptics by something like that. But all said and done, I'm with her. Not because she's a charming lady, because she's an excellent surgeon.
Doctor, yeah, sir.
I think in case of the toric lens, this is not very common, but not very uncommon also. It can rotate up to 110 degree. We have one case and we have to open and again refix it. She nicely really refixed the axis. It is very, very nicely, and I think everybody will do the same on.
Okay, thank you,
Dr.
sir.
Zia, you have to be my friend.
Sir, 1 minute. Ramurthy.
I think, you know, it's very unusual to have a rotation by exactly 90 degrees in a normal eye. There's something wrong in the calculation, in the feeding of data. Yes, it happens once in a while in all our hands. The fact is that you found it out and corrected it. And I found that you're using viscoelastic for the rotation.
So it was
Whenever I
not
have to
required.
rotate the
Yeah.
intraocular lens, the toric lens, I just go in with the irrigation cannula
Yes,
and
yes.
rotate the lens, because sometimes the visco itself causes the malrotation.
I agree.
I completely agree with, you know, even a 0.75 diopters of against the rule astigmatism, you can still go ahead with the toric intraocular lens in these cases. As far as the second case is concerned, you should understand that if you leave behind a toric lens more than 30 degrees maloriented, which was the case, actually it's going to make the pre-existent astigmatism worse.
Yeah.
So in this case, instead of a reverse optic capture, of course, after doing a good anterior vitrectomy, you could have done an optic capture. You could have brought the haptics into the anterior chamber, got an optic capture, and oriented the lens exactly in the axis that you want.
Thank you, Ram. I think after hearing both prosecutor and counsel, all the juries, I think in the first case, what you have seen is the rotate, 110-degree axis, and later on it was brought to 10. Normally, this happens when the optomes who are there and they are doing everything, and we are going in the surgery and operating, and they are telling us axis. Normally, you may or may not accept, but this happens normally. We must, as a surgeon, we must take a round in the morning of each and every patient and see patient on slit lamp for one thing, that we will have more friendship with the patient first. But second day she rotated perfectly, yes, sir. In the second case, yes, I think it was a small astigmatism, but she managed well. But I think it was possible to avoid. But I will ask the opinion of jury. What is the opinion of jury? Everybody can show me the card. She is guilty, non-guilty. I want to see from juries, all juries, please concentrate. So now I think everybody is of the opinion that she is not guilty, and so I will ask Ram to garland her. So few are there, so very well managed, and Dr. Ramamurthy will garland madam. Shall come.
It's totally non-guilty to show a cases with such a difficulty, complication. It requires the experience, guts, and the surgeon's idea. And these are surgery which gives a lesson to us to learn how to avoid things also. So it is not only to make person guilty or not guilty, it is us to learn how to improvise subsequently also. Thank you for showing those videos.
Thank you, sir. That is something that is absolutely commendable, and I appreciate, everyone appreciates the complications, daring to bear. And Dr. Surya Gupta is here, so he does IC daring to bear, and this is also with the same, be bold enough to bear what you have done. So now I call upon another very, very glamorous surgeon, Dr. Naren Shetty, all the way from Bangalore. Nobody claps for him. How dare you? everybody again mesmerized.
It's always a glamorous surgeon that are on trial. Why is it so, Partha, in your court martial?
Because you're on the jury now. So, Naren, hand on your heart. In Kannada, take your oath, please.
ನಾನು ಸತ್ಯ ಹೇಳ್ತೀನಿ, ಸತ್ಯ ಬಿಟ್ಟು ಬೇರೆ ಏನು ಹೇಳಲ್ಲ.
Okay. So, shall we start, Naren?
Yes, sir.
Thank you.
Good morning, everyone. I thank you one and all for giving this opportunity. So, we have a young patient who had a history of trauma, following which he had a complication of basically developed cataract, and also you can see iridodialysis. It's not too big. So you can see, and patient also had a little bit of phacodonosis. So I have completed my rexes. You need to be very careful, but you can see that the whole complex is not rotating while I'm doing the rexes, so it's fairly fine. And when you do your hydrodissection, again, you need to be very careful, especially when you're trying to release the fluid which is coming from behind, because if you put excess pressure, again, you can damage the zonules. When you're doing your phaco or chopping, you need to do it very slow. All your techniques, your surgery should slow down, because try to, so that you exert as less pressure on the zonules as possible, and try to rotate. If you see now the dialysis is on the right side, so you try to rotate the same way or the clockwise. That's clockwise, so that again you prevent any stress on the zonules. So once you have done this, normally what I do is, once I finish my choppings, I remove my second hand piece so that there's better fluidics and the pieces come to the phaco probe, and then I slowly emulsify the pieces. Now, what is very important is, because all of us have a tendency to focus on the lens and not on the posterior capsule, but in these cases, more so important on the last few pieces. Make sure your focus, you can make out the lens is defocused, but the bag, the posterior capsule is more focused. So it's important to focus that, because there's a high tendency for it to collapse. And every time you remove your instrument, you have to insert viscoelastic and then remove. And when you're doing your IA, again, the direction at which you pull your cortex is always towards the direction of your zonular weakness, again, to prevent iatrogenic breaks. And once you have done that, you can implant your lens. Now, see, whenever we see these kind of cases, we have a tendency of having only one line of treatment, where we think of only anchoring the iris to the sclera, but it's not that you have to follow the same in all cases. When it is a small iridodialysis like this, you can still you can go with coloboma ring. So you can see me, I mean, you have to be very delicate with these. These are very little more fragile. So I'm using my microforceps and slowly placing into the bag. And once I've inserted the segment inside, then I come out and hold the trailing part and slowly insert it. You need to do it very, very slowly, or else these can easily break, and then you have to explant and plant a new one. So what is very important is, when you release it, do not release it as anterior to the capsule as possible, so that again it does not go too deep or get stuck to some other structures. So once that is done, you can use your dialer and slowly start rotating. You have to realize where the segment is, because sometimes you can have a pupil like this where you cannot see it. You have to realize where you released it, and once you take the dialer and start rotating it, you can rotate it, the segment, to the area of the iris dialysis, and then you can position the lens slowly. You shouldn't do it very quickly again. Once you have positioned it, I think you'll cover the whole the defect, and then you can wash off the viscoelastic, and then you have a case like this. So you can see you will see the post-op day 1 image, where you can see the complete defect. I think it's still yet to come, yeah. So you can see the inferior, I mean, absolutely the complete defect is covered by the coloboma ring and fairly, centered pupil. So in these cases, before you do implant these coloboma rings, it's important to look at the eye and look at the pupil undilated. If it is centered, little change in shape is fine, but it should be centered. It's very, very important. And if the defect is not too small, I mean, it's not too big, then you can have this also as an option, instead of only trying to do a more invasive suturing of the iris to the sclera. Yeah, thank you so much.
So thank you very much, Dr. Naren. And I begin my trial. I believe this is an inappropriate technique that you have done. You have cut short. You have not been appropriate in this particular case, and it's much ado about nothing. So you just put in that iris reconstruction ring and let that whole traumatized iris be, and you did nothing to it. Were you capable of suturing the iris
Objection, Your Honor.
atraumatically? 1 minute, please. He has to answer. Are you capable of doing
no,
an
you need
iris
not answer.
repair?
I'll take
Yes or no?
Yes, sir.
Why did you not do it in this case? Were you in a big
Objection,
hurry?
Your Honor, I'll defend you.
You answer that question a little later. So the rhexis was very nicely done. Congratulations. Give him a hand. This is the only time you're going to give him a hand. Now stop. So the traumatic iododialysis, and that had to be repaired. So with a dialysis as this, it's not so difficult to repair it. And Dr. Naren, this is a learning session as well for you. You have to understand how to repair it. And the repairing is very, very easy. So what you do is, you've done a good rhexis, you do a good cortical cleanup, you put in a lens nicely, fill up with viscoelastic.
We know how to do it.
He does not.
He knows.
A deep
You will learn
anterior
something
chamber,
now.
and then do a Hoffman's pocket, a large Hoffman's pocket. You know what a Hoffman's pocket
No,
is?
we don't know.
Very good, very good, very good. Give him a clap for that as well. So
Don't.
Then-
We are not with him.
then you do a suturing right across. Be very sure that the iris is not traumatized.
Objection, Your Honor.
And 3 sutures will bring back the iris very nicely. So I find you guilty of inappropriate technique.
Okay. So I'll take over here. It's very straightforward and simple. The pupil was not distorted. The pupil was round. The patient had no visual disturbance.
Are you closing
And-
your eyes?
Yes, no, not closing eyes. For a probable small dialysis, a CTR was placed so that the patient does not have a post-operative glare at any point of time, because we do all our surgery so premium. This aniridia segment was placed there. Now, for small defects, very small defects, rarely you can ignore it. You can suture it. You could place a partial aniridia segment. It's not necessary for such a small defect. Iododialysis is the only reason. It's not a choice. Iododialysis has become a D-shaped pupil. It's become large, and majority of the case times you can't place an aniridia segment. Here it was so small and focal. It is definitely a possibility. So you don't have to teach us how to do an iododialysis repair.
I'm trying to
Just
teach
because
him.
you want to talk for 10 more minutes.
Thank you, thank you. Let's ask 2 people from the jury to comment. Yes, Rohit?
It was appropriately done under the given circumstances when the pupil was circular and everything. My one concern is you could have used Canacot to see whether there is any vitreous. That could have been used. Otherwise, I'm fine.
It's just that he's a young patient, sir. Because he's a young patient, sometimes when we inject it, it goes posterior segment, and sometimes there can be raised IOP.
I think nicely managed
No,
case.
why tricot? I mean, there was no
considering
vitreous
the,
disturbance. There was no vitreous disturbance at all.
Yeah.
Because,
Yes,
zonal
Dr.
weakness
Tityal.
only was there. No
Yes,
zonal
vitreous, no
dialysis.
vitreous.
so there was no.
No vitreous.
My
Only zonal weakness.
only query will be, now patient also had a phacodonosis, as you mentioned during your procedure. Will this mortise ring will prevent the further decentration of bag, because must have been a general deficiency at that area where you had a dialysis?
Yes, sir. So what happened, sir, while I'm doing the surgery, as you observed, while I was performing the rhexis, the complex was like a rock. It didn't move. Initially, it looked like it. I mean, everyone was suspecting it preoperatively, but when I was doing the rhexis, there was no movement at all.
Okay, you thought
of
the bag
complex.
is
Bag is
stable.
very,
You
very
didn't put a
steady,
suit,
sir.
yeah.
Yeah, absolutely, sir.
I think being
Where was this segment from?
The care group, sir. Care group.
So you
Oh,
have
one of the
Colaboma.
problems there's one way of handling a problem like this, but I think most of us would agree that, nowadays we'll go ahead and suture this, and it's with what Partha said, it's a very easy procedure to do and for a surgeon. And these segments do leach pigment. If you get it from human optics, it's different. I use a lot of care group product, but over a period of time, glaucoma, inflammation, iritis,
This is in the bag, sir.
Sorry?
This is inside
No,
the bag.
inside
Even
the
if
bag,
it's
but
inside the
still
bag.
the pigment leaching is over a period of time is a problem with these. And these are extremely fragile, and sometimes but I think
not seen, yes.
the take home would be, though this is one way of dealing with the case, Most of us, I think, here would go ahead and suture it now with the handbag technique.
Why you didn't do flax? I have a perfect indication for flax in this case.
So he did
The
such a
patient,
affordable, sir.
We should have actually appreciated how beautifully he
the
operated.
patient could either pay for flax or the segment.
Segment is not necessary in this case.
Yeah.
Yeah.
Thank you.
So, Dr. Naren, did you learn?
No.
Yes or no?
No.
My whole life I
excuse
will
me,
always learn,
it's-
sir. No point I'll not learn anything.
Wonderful. Now plead guilty and come and take your garland.
Shall I ask to garland him?
Naren.
Now we call upon another powerful lady, Dr. Manpreet Kaur. She is the power bank of RPC. Everything that you see in RPC rests on her shoulders. Yes or no, sir? Tityal, sir. Hand on your heart. In Bangla. I know, but she is in Kolkata.
So you're
Ami
increasing
jaha
my
bolibo,
difficulty.
ami jaha bolibo,
আমি যাহা বলিব
সত্য বলিব,
সত্যে বলিব
সত্য ছাড়া
সত্যে ঝালা
কিছুই বলিব না.
কিছুই বলিব না
Wonderful. Give her a hand. So, Dr. Manpreet.
So I'll be presenting a case of double decimate membrane after keratoplasty where OCT came to the rescue. So it was a 28-year-old male with macular dystrophy who was planned for a big bubble DALC. So as you can see, we marked the center, did a partial thickness definition, and as is the norm, made a groove with a blade breaker. So the corneas are thin in macular dystrophy, so without with a 30 gauge needle mounted on an air-filled syringe to try to form a big bubble. So everything is uneventful till this point. There are three types of big bubbles that can be formed between predecimetic and stroma, between decimates and stroma, or a type 3 which is in between decimates and also predecimates and stroma. So I advance the needle paracentrally as is the norm, and carefully I have a OCT guidance to see I have not perforated, and gently I'll just inject. So as you can see, a big bubble was successfully formed, and it was also confirmed on OCT in which we can see that the decimates has been pushed back. So then I go ahead with debulking the anterior stromal layers. After this, I'll mark the point on the remaining stroma with a gentian violet dye, and then make a nick with a blade breaker so that the air from the interface comes out. So viscoelastic helps in visualization and a slight magnification at this point. So all well till this point. Cohesive OVD is filled in the interface to push back the decimates again so that I can remove the remnant stroma. So if you see on the OCT images, there are two decimate membranes which I missed at that point. I am just happy not having a perforation and removing the stroma. I have sutured the donor cornea after removing the decimates from the donor. So as per me, everything was going on uneventfully, but on day 1, there was a double decimate membrane with a double anterior chamber. OCT said that the split was beyond the graft host junction, so it means it's a predecimatic and decimatic layer. The mistake, as I pointed out earlier, was missing that it was a type 3 bubble and not a type 1 or type 2. So there's a split between decimates and predecimates, as well as the predecimates and stroma, which though rare can occur in macular dystrophy because as it is the endothelium also is involved in some cases. So how to manage this now? So I went in again IOCT guidance and remove the sutures after making a paracentesis from the point of the maximum separation of the decimates predecimates. Then I just use MVR to make a small nick in the predecimates. So the air in the interface trapped between the decimates and predecimates has come out. Then Mericil sponge is used to soak out the interface air and any fluid. A paracentesis away from the site of maximum separation is used to fill in air in the AC from posterior limbus so that the decimates and predecimates both stick to the stroma. And milking of the corneal surface is done to remove any remaining interface fluid. And as you could see in the OCT on the right hand side, it's well attached. The sutures were replaced, and on post-op day 1, the uncorrected distance visual acuity was 20/32 with a well opposed graft and no interface fluid. Thank you, sir.
Give her a big hand. She is from RPC, the apex institute of our country. Yes or no? Yes, or
sir.
no?
Yes,
Say
sir.
yes, proudly, yes.
Yes,
And
sir.
she's an honest person who has said it was a mistake. So we can find her guilty. Are you guilty?
No,
Sir,
she's
to
not
err
guilty.
is human, to forgive divine.
You are not honest. She is honest.
No.
So shall I begin my trial? So Dr. Manpreet, I'm not a cornea surgeon.
Yes, sir.
I have learned many things now. So type 1 big bubble, separation of the deep stroma and the predecimates layer, the Duas layer, yes or no? Did I
Yes,
learn
sir.
right?
Yes, sir,
Thank
you
you.
learned correct.
Thank you. Did you all learn?
Yes.
Yes or no? You, every one of you. Yes, Shubroto, say yes.
No.
Yes. Type 2 big bubble, separation of the predecimates layer, that's the Duas layer, and the decimates.
No,
Did I-
sir.
No?
Decimates and stroma.
Decimates and
So
stroma.
the
Okay,
air
I
goes in
will
there.
retype that.
Yes, sir.
Okay, thank you. Type 3 big bubble, combination of type 1 and 2. The 2 bubbles are formed, 1 in each plane.
Yes, sir.
Thank you, I learned that right. So, in this case, the type 3 big bubble was formed. Type 2 unrecognized during the surgery.
No, sir. It was only type 3. It cannot be both.
How did you miss the separation during the surgery in spite of having a live ASOCT?
Because, sir, I was
How
looking
did
in
you
the
miss
eyepiece,
that?
not the screen.
Not
the OCT screen, I was looking in the
you
surgery.
have everything, all and everything that
Objection,
you wish.
objection, Your
and
Honor.
yet, you are glued only to the microscope and you will not take a sneak to the screen.
Objection, Your Honor.
You are guilty. No, wait.
What else have you to say?
After identifying the issue, on table management can be done. First, without complete dissect
Sir,
of
but
the
your facts
predecimates.
is wrong. There was no type 2. It was only type 3.
Okay,
Okay,
you explain me
what?
why
I'll
did you
tell
not look at the
something.
screen?
You could go back, read and come back.
I think,
We'll
I
have
think,
this on next court martial.
please carry on.
Yeah,
Difference
please carry
counsel,
on.
make it
See,
short.
essentially, in a macular dystrophy, let's all understand that this kind of a issue can rarely happen. And which is what has happened. And it's not that you expect it to happen. She might have thought that Bubby was in AC.
Might
and she
have
never
thought.
expected that moment person, the ASOCT, don't keep looking at it. You're operating. She's doing everything well.
What? Give
She
the
noticed
ASOCT
it,
to me.
and the very next day she sorted it out. So this was a beautiful learning video, a teaching that in macular dystrophy, be conscious that such a thing can happen and how you deal with it. Thank you, public prosecutor.
Of not seeing
Let's,
the ASOCT.
please, let's have the two cornea surgeons in the jury commenting.
So,
Dr. Somshila and Dr.
Should she have seen the ASOCT or not?
No, it is not.
We,
so,
now,
it is
now
not,
my defendant doesn't talk.
I would request both of you to keep quiet.
So as nicely summarized by the non-cornea surgeons about this case, that yes, it is not very rare. It's known that you can have splitting of the DM in macular corneal dystrophy. That's one of the known things. So the more you keep operating, you keep looking out for that. About the intraop OCT, the accusation is that she should have been looking at that. But it's not that easy to look at that intraop OCT while you're dynamically operating. And there's a lot of undulations. So if you're not expecting it, you may not see it. I wouldn't pick it up because I don't have experience with intraop OCT. So it would be probably more experience, and Dr. Tityal would say. And I think the main here, the point is that as soon as she identified, she managed this case very beautifully.
Very
because
beautiful.
even management can be very tricky. And if she had used another approach of just going into the AC and injecting air that wouldn't have solved the problem. So the managing the complication was extremely well done.
Yes.
So not guilty.
Yes, Chief.
One thing I agree that management was done very nicely by her, but I don't agree to the fact that, you know, when we are doing a lamellar procedure, it is must to be seen through the OCT. Where every step, you know, we have to see. Otherwise, what's the point having OCT
No, no.
there?
There is no hanging
Just
here.
hold on. Once you have a device, you must see, especially lamellar procedure, we know that you can have, you know, things remaining there. Your dissection may not be proper. Your needle may not be in a proper position. You may have a double chamber. So that has to be seen at the end of surgery or a beginning of surgery. I know that you have used the standard microscope with OCT. You didn't use the Artigo 800. 800 would have given you the entire access of seeing everything by the surgeon. But that thing is there, but we should learn that if you have a device, you must see it at the end. You could have managed the case on the table at the same time. And next day your cornea would have been very, very clear, like you saw after the repeat intervention. So that part we have to learn.
I think it's been nicely summarized, but your topic says ASOC to the rescue. Actually, you didn't use the ASOCT. Online ASOCT.
Post-op ASOCT.
No, post-op.
IOCT didn't
because
come to my
even in your
rescue.
post-op images, what you showed, there is a bubble which is separating the Descemet's membrane. If only you had a look at the instrument which was readily available in the OT, maybe you could have avoided a second surgery, but the ultimate outcome was good. And she's again a lady, so guilty or not guilty?
Not guilty, not guilty. Our cornea surgeon says
The
not guilty.
truth,
You have to
the
start
honesty
using the
remains.
intraop OCT now throughout your surgeries. Sir, intraop OCT का microscope उनको देना है रोज.
I think what she managed very well, and okay, OS OCT we should use and see whenever you are putting the bubble. So, but management is good, and you are not guilty. I will ask Somshila to Garland.
But let us give a rousing applause by which she has presented, and Dr. Tityal has given the right scientific outlook. This is science. This is beyond court-martial. This is science. Big applause.
डालो.
अपनी तो जैसे तैसे थोड़ी ऐसे या ऐसे अपनी तो जैसे
And here we are.
आपका क्या होगा जनाबे हाली
एक ही है और क्या? एक ही है. आप क्या होगा जनाबे आली?
अरे बिल्कुल अच्छा होगा अभी.
So, hand on your heart in Kannada. Your oath, please.
ನಾ ಏನೇ ಹೇಳಿದ್ರು ಸತ್ಯವನ್ನೇ ಹೇಳುತ್ತೇನೆ, ಸತ್ಯವನ್ನು ಬಿಟ್ಟು ಬೇರೆ ಏನು ಹೇಳುವುದಿಲ್ಲ.
Naren, did he curse me?
जो भी कहा होगा सत्य ही कहा होगा भाई, कर्स भी सत्य में ही कहा होगा.
Okay, shall we begin?
Good afternoon, everyone. So, I am presenting a case where the scleral buckling was being done by my colleague in the another OT. Everything was going well. So, it's a 39-year-old lady with rhegmatogenous retinal detachment taken up for the scleral buckling. But while SRF drainage was being done, unfortunately, the blood started entering into the subretinal space. And then it moved towards into the macula. So this was my colleague trying to drain it, like how routinely we try to drain the subretinal fluid after putting the belt. You can see there. So the SRF fluid was coming pretty well, but looked something reddish. On IDO examination, now we can see the blood has traversed on into the macular area. So in these cases, we have to shift it to vitrectomy. And PVD induction is very, very important, especially since it's a 39-year-old lady. PVD induction is very, very important in these cases. So fortunately, I could get a good PVD induction also. If you can see there, IVTA assisted staining of the vitreous and then inducing the posterior vitreous detachment. Now, to be less traumatic, what I did was try to make a small retinotomy in the mid-peripheral area and then try to drain the blood through that
retinotomy area. So for which I had to do a fluid air exchange so that the blood moves up to the periphery. So if you can see there, I was trying to aspirate it, but since it was already clotted, so I couldn't remove it. So I had to remove or take a technique where I can remove it in toto. So carefully, I tried to go inside that retinotomy and try to remove that blood in toto with a gentle suction. Because if you apply more suction, then the retina might come into the cutter. Now you can see here, I am just trying to remove that blob of blood, and fortunately it came just in one go. You can see again re-grasping it, using the light pipe, trying to push the retina away so that it comes out pretty easier. And now you can see this is the thick blood which was under the fovea. And finally, put a PFO and then laser that retinotomy edges. And retina settled well, non-expansile C3F8 gas. This is the post-op. You can see the patient really improved very well. 1 month post-op. The OCT also shows pretty much normal. And 3 months post-op, the patient improved to 6/9 vision in this case.
Amazing.
Thank you very much.
And 6/6, no? You could have really, you could have really pushed the person to 6/6, brought the Snellens a little closer.
Yes. Sir, you asked me to take a oath in my language touching the heart, and now if I am telling the truth, you are not agreeing, sir.
Partha, they keep the chart right in front.
Okay, so we are surgeons. Dr. Vivek Datta, come and take the first seat. Dr. Zia ul Hassan is there.
I can protect him well. Don't you worry about that.
Manoj.
Unless you're scared of me handling you.
They are there to protect him as well. So, beautifully edited video, Dr. Srinivas Joshi, as usual. You have a fantastic team for editing in your hospital. You didn't show how the SRF drainage was attempted, whether cautery to the drainage site or not.
Cautery was not done to the drainage site, and as I said, sir, it was done by my colleague, and I had to go in for the rescue.
Okay, a colleague did it. Okay, fine. Always colleagues do wrong, and the savior is Srinivas Joshi. On careful observation, at the drainage site, the needle has punctured the retina. It means there was a thin layer of SRF. So drainage was not necessary, only buckling the primary break could have been sufficient, or the site of drainage could be wrong and a major blood vessel punctured, gross negligence. So which do you accept? Why vitrectomy was planned in the same sitting? Initially, injection of C3F8 with the face down position could have been done. This might have dislodged the clot from the posterior pole. And why did you not enlarge the puncture site a little bigger for easier removal of the clot?
Objection, Your
Find
Honor.
you guilty. What objection?
No,
Just a second.
no, that the issue is don't dramatize
There
it
was,
just by writing so many
posterior.
sentences. Initially,
Can you read
there was an error that first needle puncture has happened.
Let
and
the
then
poor
he has
man
done
answer.
everything step by step. He has discussed how he has done it. Does he have to repeat it?
Sir, subretinal-
He has tried to soft tip, and then he has used a cutter, and how
Cutter.
beautifully the entire clot came off. And so, this patient is never going to have a redetachment.
Look at the
A
science,
buckle
not
has
the
been
beauty.
done and a vitrectomy
I
has
think it was
been
a
done.
quite
Dr.
posterior
Mohs.
break. You couldn't
Yes.
have buckled it anyway.
Yes.
Quite a posterior
Sir,
break.
the third point, we can't wait for C3F8 to dislodge because it was a
Thick
huge
clot.
blood clot
Huge
which was covering the entire posterior pole.
Yeah,
So
I
we
think,
couldn't take the risk because it was
Just a minute, Srinivas.
Okay.
We'll take a comment from the jury.
Please
Dr.
finish,
Mohan.
finish fast because my next session is mine.
Dr. Mohan, quick comment from your side.
Okay.
I think it has done a good job. Done a good job. Fantastic.
We are
Srinivas.
Mohan is
Take a-
also a retina surgeon.
Yes. Thank you
Zia,
for remaining.
Dr. Zia, Dr. Vivek Datta, any VR surgeon, your opinions?
Manoj.
In case of the buckle, the most important thing how
Please come.
how to release the SRF. At the time of SRF should be more cautious, more magnified image, so we can avoid the subretinal hemorrhage.
I agree, sir, because induction of the cautery or the laser to the choroid probably would have prevented this event to happen. But most of the time, we do this happens only in 1 or 2 in 100 cases. But still, the caution could have been exercised.
Yeah, we can.
Are you
take your
guilty?
comment. No, no, no.
No, not guilty.
Yeah.
Sir, it's a complication written in the textbook, sir.
Vivek.
I think the surgery was done beautifully, but since it is a fresh hemorrhage percolating into the macular area, I think you could have observed it, and with the gas,
Prone
that
position.
could have helped the blood to, get dislodged.
I tried, sir.
It's quite a large one, sir.
Sir, but
Very difficult. It's quite a large one.
Quite a very big large.
And causing laser, it could have,
That clot would not have come.
PVR
No,
changes.
if you
So
see
it
that
was a very
video, it's
small
quite a huge one.
retinotomy which we did. I did not do a retinectomy, large retinectomy. If you could see the video, sir, it was less than a half clock hour which the retinectomy was done. So it was pretty small area which we did it.
we'll
And
take,
39
Srinivas,
year old, we don't
we got
take
it.
risk. Yeah.
Dr. Manoj Khatri.
Yes, sir.
Yes, very nicely managed case, Srinivas. But as the opinion of the house says, first choice would have been given observation with just a gas injection or even an air injection for some time, at least 2 or 3 days, and then we would have to consider vitrectomy for this patient. Primary vitrectomy at the same setting is little more aggressive, I believe, because the outcome can be either ways. You already had an open, conjunctiva there with a poke inside and the bleeding going inside. So primary vitrectomy should be done with
Manoj.
caution.
So we can have a verdict from the jury, and Srinivas nicely presented.
Just one point, sir.
Yeah.
Thank you.
Just
Just one
one
point,
question
sir.
to Manoj.
Just one point, Titial, sir.
Manoj, one
If
question to
I had
Manoj.
not gone inside and raised the pressure to 60, it would have bled more.
Yeah, that's
So I had to stop the bleeding. So for which when I got to know that there was altered fundal reflex when the drainage was going on, immediately converting it into the vitrectomy is very well published and increase the
but
infusion will
message
stop the bleeding.
What we have to drive here is this is not suprachoroidal hemorrhage. This
Yeah,
is
so we
subretinal
end
hemorrhage.
this case
There
over
is a
here because
difference
of
between
paucity of
Hey,
time.
Ari, Duki,
So just
science
a
bold है.
message to the audience, subretinal hemorrhages can be observed and managed at a later date if required. As compared to suprachoroidal hemorrhage, then we have the outcome is totally different and the management is totally different. That's what I want to say. Thank you so
Thank
much.
you.
Thank you.
So we can garland
So
him.
non-guilty. Yeah, please garland him.
Thanks.
Yes, Srinivas,
Hey,
come
boss.
forward.
Yeah.
अरे फोटो
दूर नहीं है, गार्लैंड है.
Everybody for the photograph.
Partha, this was a very nice session with full house. 125th session in Kolkata. We really enjoyed the court martial.
Friends, please stay back for the IOL fixation course, which is going to start in another 1 or 2 minutes. Thank you very much. we can't afford to waste time. Yeah, we have a very packed program.